Infertility is nowadays has become a growing health hazard. If we compare the fertility problems compared to about 2 decades ago, the fertility problems have gone up by 50%, and this is mainly attributed to the lifestyle changes. Both in females and males, this has become a big problem. And nowadays, if you see, male and female fertility contribute equally. Earlier on, it was that female was the main cause for fertility problems, but now we see that there has been a drastic increase in the male fertility problems as well. So, what is this infertility? When do we call a couple as infertile? We call a couple infertile when they have tried for 1 year without using any contraception. Even after trying for 1 year, if they don't get pregnant, then that is the time when they have to seek help to get pregnant. And this 1 year is just not a cutoff point. We want to ensure that they have tried adequately in that 1 year without any contraception. And if we look at a couple, the chances of them getting pregnant in 1 year is just about 20%. And that is the reason they have to try for 1 year before they start actually getting worried as to why they are not getting pregnant. Usually it is about 85% of the couples get pregnant in the first year of trying, and then about 93% of the couples get pregnant after trying for about 2 years. So that is that 7% of the couples who have difficulty in getting a pregnancy. But what happens is, a normal couple, when a woman is less than 35 years of age, if she's tried for 1 year, they can come and see a doctor. But if the woman's age is more than 35 and she's about 35 to 40 years, just after trying for 6 months, I think that is the time when they have to go see a doctor. But if she's more than 40 years, then after trying for 3 months, they have to go see a doctor, because we very well know that with age, the fertility potential goes down. When I say trying adequately means trying exactly during the fertile period. Fertile period is a time when a woman, when she has got regular cycles, that means that she's got a cycle of 30 days. So once in that cycle, there is one egg which gets ovulated, and that is that time when she has to have intercourse. They have got a window of about 24 to 48 hours when they have to try for a pregnancy, and that can vary between anything between day 12 to day 16. So it is often advised to the couples who are trying for a pregnancy to try adequately from the 10th day of their periods to up to 18th day of the periods every alternate day. That is actually called as trying adequately. Conception happens. This is the uterus. These are the tubes, and these are the ovaries. A normal cycling woman, that is a woman who has got periods which last for 30 days, in that woman there is one egg which ovulates either from this ovary or from this ovary every month in the mid-cycle. So that approximately happens on the 14th day. So one egg gets released from the ovary, and that is called as ovulation. That is picked up by the tube. And at that point, if they have intercourse, then the semen is deposited here in the vagina. The sperms travel up from the cervix into the uterus and enter the tube. And in the tube, both the egg and the sperm meet, fertilize, and then they travel back into the uterus and get implanted. The process of fertilization and coming back to the uterus and getting implanted takes about 5 days. So the sperm or the egg are alive for 24 to 48 hours, and this is the window period when the couple has to try adequately. That is the reason they are advised to have intercourse every alternate day from the 10th day of the period to the 18th day of the period. The editing part. Now if we have to see, there are about 15 to 20% of the couples are infertile, which accounts to about 30 million couples in India presently are infertile. And this rising fertility issue is more because of the changes in the lifestyle patterns. The changes in the lifestyle patterns, when I say that, it means that especially in urban India, wherein women are more career oriented, and because of education, they're delaying their marriages and postponing their childbearing, and this is the reason the fertility problems are also on the rise. Earlier, if you have to look at it, before the age of 20-25, they would have finished their family and probably a hysterectomy as well. But now in our clinic day to day, we see that a lot of women are planning their pregnancies only after the age of 30. This is one major concern. because we very well know that the fertility potential, that is the number of eggs and the quality of the eggs, declines from the age of 30 and drastically goes down from the age of 37 and 38. And by the time they come down to 40 years, almost their chances of getting pregnancy goes down to just about 5%. So it's an advice to all the couples who are trying that females going beyond 30 have to be very careful that they plan their pregnancies prior to 30 years so that the chances of them getting pregnant is more. And lifestyle issues, the other reason for increasing in fertility problems is that because of sedentary lifestyle, irregular eating habits, and then lot of work stress which they carry from workplace to home, and then they hardly have any personal relation with the husband because they work in night shifts and hardly get to see their husband. I think it's just on the weekends that they meet each other, and this is all attributing to increased fertility rates, increasing fertility problems. And this is just not in females but in males as well. If you have to look into, men are getting addicted to a lot of smoking and alcohol. All these is detrimental to the quality of the sperms. Not only that, their working pattern, like sedentary lifestyle, wherein absolutely they have no physical activity. In them, obesity is becoming a major concern, and because of this, there are a lot of hormonal problems which are coming up, and due to this, there is a decline in the sperm quality and the quantity. And exposure to a lot of pollution and exposure to Wi-Fi, mobiles, and all this is also attributing to decline in the sperm quality, thereby attributing to increase in fertility problems. A couple, when they're trying for a pregnancy, it's a concern that when they should actually go seek help. The couple is advised to go seek help when, if her age is less than 35 and has tried for 1 year or more, and more than 35 years after 6 months of trying, and also when the female has got irregular cycles. When I say irregular cycles, she's got cycles which may last come once in 2 months or 3 months, or if she's got heavy bleeding, or if she's got pain during bleeding, or if she's got scanty bleeding, or if she's got pain at the time of intercourse. All these symptoms are very important. If she's got any of these problems, they don't have to wait for a year's time. I think that's they have to see a doctor immediately to understand what is the background problem, because it could be an adenomyosis, or it could be an endometriosis, or problems with fibroids, or hormonal imbalances causing polycystic ovarian syndrome, that is, we commonly call it as PCOS. And women who have got surgeries, like any abdominal surgeries previously, for appendicitis, for ruptured appendicitis especially, or any intestinal surgeries, I think they have to see a doctor immediately, because that can arise to tubal problems, that can lead to tubal blocks. So they also have to seek help immediately. And when it comes to males, when they have problems with intercourse, that is, problems with erectile dysfunction or ejaculatory dysfunction, and also when they have anatomical defects like hypospadiasis, etc., they have to seek help immediately and not wait for a year's time. HSG is one of the tests wherein we are going to look if there is a tubal block or not, especially when we are trying to evaluate a couple. The 4 factors which we are looking at: first is ovulatory, second is the tubal, third is the uterine factors, and the fourth is the semen factors. So when we are suspecting a tubal block, especially if she's got a previous infection or any history of tuberculosis in the past, or if she's had any surgeries in the past, they are the ones who are at risk of having a tubal block. In them, the basic test to identify if there is a tubal problem or not is HSG. That test is a non-invasive test, and it is the first line test which is done for most of the women. HSG, wherein a dye is sent from down below from the vagina into the uterus, and then X-ray films are seen to see if the dye comes out of the tubes or not. So we send, with the help of a catheter, we push some dye into the uterus. The dye enters into the cavity of the uterus, and then the dye is expected to come out of the tubes and spill outside into the abdomen. And at this point, X-ray films are taken to capture the spill of the tubes. So, but one thing we have to remember that in a HSG, the sensitivity of the test is just about 60%. So, when we do this HSG and if there is a block, then we cannot be 100% sure that there is a block because the sensitivity is just about 60%. And the more definitive way of confirming if there is a tubal block or not, we'll have to go in for a laparoscopy. Laparoscopy is the gold standard test to look for tubal blocks. If we have to understand that laparoscopy is not a form of treatment. We have diagnostic laparoscopy and operative laparoscopy. A diagnostic laparoscopy is done to identify if there is a problem. Like usually we look for if there is a problem with the tubes, or if there is any PID we are suspecting, or if we are suspecting any endometriosis or something. So diagnostic laparoscopy is just done to look for if there is any problem. And then operative laparoscopy is done for n number of reasons. It could be if there's a cyst in the ovary. Cyst in the ovary could be because of endometriosis, or it could be some simple cyst. There can be n number of reasons for a cyst to come up there. And also if there is an endometriosis wherein there are a lot of adhesions in the uterus, or if it is a PID, or because of tuberculosis when the tubes are blocked. So it depends on the reason why we are doing a laparoscopy. Laparoscopy is not a treatment. It is just a procedure to look for problems and to correct if there is any problem, like as I've earlier mentioned. So just doing a laparoscopy is not a treatment for a pregnancy to happen. HSG is a test wherein it is a diagnostic test done to look for tubal patency, to look for if the tubes are open or not. So that is an outpatient procedure which is done immediately after periods. The ideal time to do a HSG is on the day 7 or 8 of the cycle, wherein what we do is there is a catheter which is inserted into the vagina and into the cervix, and through that catheter, this procedure is done by passing a catheter into the vagina and into the cervix. Through this catheter, dye is passed into the cavity of the uterus, and we see if the dye is entering into the tubes and spilling out into the abdominal cavity or not. At this point of spillage, an X-ray film is taken to see if the dye is coming out from this tube and as well as this tube. It is very important that HSG is done. HSG gives us a lot of information on how the cavity is looking like, and if there is a block, where is the exact location of the block. HSG, that is hysterosalpingography, is an important test which is done to check for tubal patency. This test is done as an outpatient procedure and ideally done between day 7 and 8 of the periods, wherein a catheter is placed into the vagina and into the cervix, and through this catheter a dye is passed, and the dye enters the cavity of the uterus, and then the dye enters into the tubes, that is both the tubes, the right and the left, and then it is expected to come out of the distal portion, from the distal portion of the tubes. And this passage of the dye into the cavity and into the tubes is captured by an X-ray. So with this procedure we get a very good outline of the cavity. If there are any defects in the cavity, that is if there are any polyps or if there is any submucous fibroid, that also can be diagnosed by doing a HSG. And also it gives us good information about the shape of the cavity. If there is any uterine anomaly like bicornate uterus or a septate uterus, this also can be diagnosed by doing a HSG. And apart from looking at the cavity, it gives us good information about the tubal status. If the dye can pass freely from both the tubes, then it means that the tubes are 100% patent. If there is a block, the blocks can be of different types. The block can be a very proximal block, which is at this cornual block, at just the entrance wherein the tube is meeting the uterus. That blocks are usually because of spasm. That is, when the dye is sent, there can be a temporary physiological spasm because of which the tubes can just close and the dye may not enter into the tubes, and usually that is seen bilaterally. That will happen. It's not like the corneal spasm can just happen at one side. Usually it happens on both the sides. And then we can also see at the site of the block of the in the tube as well. It could be anywhere. It could be at the ampullary region, or it could be just a femoral block also. So with this HSG we can get clear information as to what kind of a block it is. But we have to bear in mind that when there is a block in HSG, it is not 100% sensitive. The sensitivity of this test is about only 60%, and to have a definitive diagnosis on whether this block is there or not, we have to go ahead with doing a laparoscopy. That is a diagnostic laparoscopy. Diagnostic laparoscopy is the gold standard method of diagnosing tubal blocks. HSG usually is considered to be a very painful procedure. Yes, we do understand that this can be a bit uncomfortable, but it is definitely not a very painful procedure, and we usually take care and advise giving some painkillers prior to the procedure, and it is followed by giving antibiotics after the procedure. Causes for infertility can be both in female and male, and they attribute equally for this. Usually we see that 40% is caused by females and 40% is caused by males, and the rest 20% is usually unexplained. So when coming to female factors for infertility, the first and foremost is ovulatory problems. That is, these women have problems with ovulating. That is, they don't release the egg. There can be problem with the growth of the egg and can be a problem with the release of the egg. And this happens because of hormonal imbalances. And hormonal imbalance can be in different forms, like it could be because of PCOS, wherein there is a problem with increased androgens in the body, that is male hormones problem, and then there could be thyroid problems, there could be prolactin problems. So hormonal problems usually attribute to these ovulatory problems. Then comes the tubal factor. Tubal factor, that is when there is a block in the tubes, and tubal blocks can arise from previous past infections like tuberculosis or PID, or if they have had any abdominal surgeries in the past. And the next comes is the uterine problems. Uterine problems, there can be some congenital defects in the formation of the uterus. That is, they can have a bicornuate uterus, or they can have a septate uterus, and uterine didelphys. There are n number of congenital anomalies which are present with the uterus and the cervix. And then comes the premature ovarian failure. Usually we expect that an average woman will attain menopause at the age of 50 years. But in some women we notice that they attain this menopause very earlier on. That is, it can happen any time before the age of 40. And this can be because of genetic problems, or it could be because of if they have taken any chemoradiation, or if they have undergone any ovarian surgeries, and sometimes it is unexplained. And the other cause of infertility can be endometriosis. Endometriosis is a condition wherein the lining of the womb, which is called as the endometrium, is present elsewhere in the pelvic organs. That is, this lining of the womb, which is called the endometrium, can be present in the ovaries, can be present in the pelvic area, can be present in the pouch of Douglas, and also be present in the wall of the uterus. This is one of the common problems of infertility, wherein it attributes to about 5 to 10% of infertility. This presence of endometriosis hampers fertility by causing problems with improper egg development, and disturbing the tubal anatomy, and also causes problems with implantation. The other causes of infertility is presence of fibroids and polyps. Fibroids can be of three types. It can be a submucous polyp, submucous fibroid, or it could be an intramural fibroid, or it could be a subserous fibroid. Especially the fibroids which are submucosal fibroids are the ones which can cause fertility problems. And then coming to the male factors usually it is manifested as problems in the semen parameters. When we do a semen analysis, there are three parameters which we look at. The first one is the quantity, that is the number of the quantity of the sperm seed. Second is the quality, which is shown by the morphology and the motility. If there is any decrease in the quality or the quantity of the sperms, they can have problems with infertility. So when we do a semen analysis, the cutoff point, the cutoff count, what we expect is about 15 millions per ml, and motility is 42%, and the normal forms is more than 4%. So when we see a sample with low sperm count, or if it is absolutely zero sperms, then we'll have to analyze and look into as to what is causing these problems. There could be two types of problems. One is that there is production in the testis, but for some reason, if there is an obstruction, it is not able to come out into the ejaculate. Or the second cause for low sperm count or absent sperms could be because of two reasons. It can be of two forms, that is, it could be because of obstructive reasons and could be because of non-obstructive reasons. In obstructive, what happens is the sperms are being produced in the testis, but for some obstruction during in the pathway, the sperms are not able to come out into the ejaculate, and this could be because of congenital absence of vas deferens, or if there is any block in the vas deferens, or if there are any epididymal cysts or block in the ejaculatory duct. And when it comes to non-obstructive causes, there is a basic problem with the production of the sperms. The production of the sperms is compromised, and this can happen because of various causes, like it could be because of hormonal causes. If there is a decreased production of the hormones from the brain, then the testis would not be able to produce enough sperms. And there could be other hormonal imbalances like thyroid also can cause decreased sperm production. And apart from this, if there is a trauma to the testis, then also the sperm count can go down. And if the person has been exposed to any chemoradiation or some kind of radiotherapy, or if they have been on some anti-cancer treatments or any other medications, then also the sperm count can go down. Not only this, the general health also decreases the quality of the sperms. That is, if they are suffering from diabetes, or if they are suffering from blood pressure problems, or if they have got cholesterol problems, all this attributes to decrease in the quality of the sperms. And apart from this, the other thing would be genetic problems. If they have got any chromosomal problems or microdeletion of Y chromosomes, then in them the sperm count can go down.